Hi everyone, in Journal Club, NPT India. Myself Sachin Gupta, Assistant Professor, Department of Physiotherapy, Amar Jyoti Institute of Physiotherapy, affiliated to University of Delhi. So today I am presenting a systematic review on intervention to prevent falls in older adults, which is published online on June 4, 2024 in JAMA. So let's move forward. So the main aim for this particular review is to evaluate the effectiveness of the interventions and identify the best interventions among them. The background epidemiology of falls in older adults. Falls are the leading cause of unintentional injury related death among adults, equal to or more than 65 years in the United States. Of course, in India, it is equal to 60 and above. In 2018, 27.5% reported equal to or more than one fall, which is corresponding to 714 per thousand. 10.2% reported fall related injuries, corresponding to 170 per thousand. Fall related mortality has increased by 41% over the past decade, from 55.3 oblique 1 lakh in 2012 to 78.0 oblique 1 lakh in 2021, represents a substantial public health burden, leads to injury and loss of independence. So, the scope of review is to develop around two key questions, that is KQs, that will be discussing further. KQ1 is effect of fall prevention interventions on health outcomes, and KQ2 is harms associated with these interventions. Key update from previous review were excluded vitamin D supplementation intervention and included participants with mild dementia, osteoporosis, osteoarthritis, and sarcopenia. So these, for example, dementia was included due to specialized care and limited generalizability. Okay, so vitamin D supplementation studies were already evaluated, separated in previous reviews. Okay, so public input process was there. So there was a draft framework was done, review questions were put and criteria posted on the USPSTF website. Duration during which the responses were taken were April 21, 2022 to May 19, 2022. Outcome was only minor revision made for clarity. So data source and search strategy. Databases were Medline, Sinhal, Cochrane Central. Time frame Jan 2016 to May 2023. And ongoing surveillance till March 2024. Additional sources were used where expert suggestions, journal alerts, table of contents scanning, and clinical trials which are ongoing through the government websites were taken. So, study selections. So, inclusion criteria was RCTs, age more than equal to 65, community dwelling, older adults, fall prevention focus. Exclusion was dementia, surgery, nutrition, vitamin D assistive tech. So participants were excluded, not feasible in primary care settings like surgical intervention, not directly related to fall prevention, which is nutritional and fluid therapy, okay, and assistive tech, for example, outside the scope of this analysis. So outcomes. So the first outcome, evaluate the health outcomes, which may be fall related injuries like fractures, hospitalization, mortality, quality of life, and activities of daily living. The second key question was the harms or the adverse events. So data extraction was done by two independent reviewers. The third reviewer resolves conflict and standardized tables were used. Statistical analysis was done by using random effect meta analysis and NAP Hartung adjustments. So it assumes variation between studies, and the NAP Hartung adjustment was used to improve. It improves accuracy of confidence interval, which is more reliable when more number of studies is small. Then relative risk was used. If it is less than 1, there is a reduced risk. If it is equal to 1, there is no effect. If it is more than 1, there is an increased risk. Level of significance was used, less than or equal to zero point zero 0.05, considered statistically significant. Heterogeneity and bias. So these were evaluated using chi-square and I-square statistics. Basically, heterogeneity was used by evaluated by using these two, while publication bias was evaluated through funnel plots and Eggers test. Spatial analysis was used. Longest follow-up used. Data taken from the longest available follow-up period reflect sustained long-term effects of intervention. Cluster RCT adjustment, ICC is equal to 0.05. It accounts for grouping of participant, example clinics, communities. ICC is used for adjustment for similarity within the group, prevents overestimation of treatment effect. Meta regression factors, age, gender, study quality. So explored reasons for difference between study result on the basis of factor analyzed are age, gender, and study quality. So focus was on exercise intervention, multifactorial intervention, software use Stata version 16.1. So this is an analytical framework, that is fall prevention in older adults. This slide represents the analytical framework used to evaluate interventions aimed at preventing falls in older adults. The target population includes community dwelling adults aged 65 years and above. These individuals are divided into two categories: unselected population, that is general older adults; increased risk group, those with higher likelihood of falls due to factors like previous fall, balance issues, or comorbidities. So there is pathway 1, which checks the effectiveness of intervention. The framework examines whether fall prevention interventions reduces the number of falls, decrease fall related morbidity, injuries, fractures, lower mortality rate. This directly answers key question 1: do these interventions actually improve health outcomes? It also considers how increased risk is defined across different studies or trials. The second pathway, harms of interventions. While interventions may be beneficial, they can also have potential adverse effects. These may include injury during exercise programs, medication side effects, over-dependence on assistive devices. These corresponds to key question 2. Do fall prevention strategies causes any harm? This slide shows the study selection process used for identifying relevant research on fall prevention in elderly. So result overview, basically first question, our key question was, do fall prevention intervention reduce falls, fall related morbidity and mortality? Studies included 83 randomized controlled trials and the total number of participants were 43,901. Two main interventions basically used, whether exercises or multifactorial interventions, which corresponds to 37 and 28 respectively. Multifactorial intervention characteristics, participants were 27,784, mostly Euro-based. Mean age was 72 to 85 years, higher fall risk than general population. Key features, comprehensive assessment, individualized interventions, multi-domain approach, exercise, medication review, environment modification, vision and hearing. Multifactorial intervention results. So positive outcome was there was a decrease in fall. The IRR was 0.84. That means there was a 16% reduction in the falls. No significant effect seen in people with less than, more than or equal to one fall. Injurious fall, fractures and high heterogeneity was seen by I square is equal to 85%. Multifactorial clinical impact, absolute benefit, prevents 114 falls per 1000 older adults. It is helpful for reducing fall frequency and limited effect on serious outcomes. Now we will talk about exercise intervention characteristics. The total participants were 16,117, basically from Europe, Australia and New Zealand. Mean age 68 to 88 years. Type of exercise, balance, training, strength training, walking program, group or home-based session. Exercise intervention results in significant reduction of fall. People with equal to or greater than one fall, injurious falls. There were no significant effects seen in fractures and injurious fall risk at person level. So you can see that the incident ratio rate and the relative risk was good enough for significant reduction. Exercise clinical impact, absolute benefit per 1000, prevents 107 fall, 22 people from falling, 27 injuries. So exercise is the most effective intervention. Heterogeneity and bias, high heterogeneity in both the intervention, not explained by age, study quality, setting. Publication bias, not detected in Eger test, which is non-significant. So the key question 2, the harms by multifactorial interventions. There was a limited reporting, mostly minor adverse events, back pain and musculoskeletal symptoms. So rare serious events were seen in multifactorial intervention given for fall. Harm for exercise reported in 50% trials. Common muscle pain, discomfort. Rare harm was seen In falls during exercise, that is 0 to 11%. Serious events less than 1%. Overall, exercise is safe. So key takeaway was exercise intervention is the most effective. It reduces fall and injury both. Multifactorial intervention reduces falls only, no strong effect on major outcomes. Both intervention are safe with minimal harms. Clinical implication: recommend exercise program as first line of intervention. Multifactorial approach useful for high risk of individuals. So, this is a literature search flow diagram where intervention to prevent falls in older adults. Here, we have seen there were 367 citations identified from 2018 USPSTF Fall Prevention Review. It was done in 2018, so it is basically from there. Okay. Then we have 4,754 citations from database searches after removing duplicates, 21 additional citations from other sources like references and experts. Then there is a screening phase. A total of 5,142 titles and abstracts were screened. Out of these, 4,739 studies were excluded at this stage due to irrelevance. Eligibility phase: 403 full text articles were assessed in detail for key question 1 effectiveness and key question 2 harms. Okay, so for key question 1, 258 articles were excluded, and for key question 2, 338 articles were excluded. So therefore, the included studies for KQ1 were 83 trials. Okay, and for KQ2, total 30 trials, and 65 articles, while for KQ1, 145 articles. So discussion, overview, update of USPSTF 2018 review. So it is an update. So we have added, there were 3 new multifactorial trials, 19 new exercise trials. Finding consistent with previous evidence, includes broader population, mild dementia, osteoporosis, osteoarthritis, and sarcopenia. Multifactorial intervention interpretation. Key findings are: only fall rate reduced significantly, no benefit in injuries, fractures, and people with fall less than, equal to, and greater than 1. Possible reasons: improved standard care in control groups, complex multi-step interventions, poor adherence at multiple stages. So the insight will be effectiveness limited by real world implementation challenges. Interpretation for exercise intervention: strong evidence for reduction in falls, decrease in people with falls, decrease in injurious falls, change from previous review, no longer significant for individual risk for injurious fall. Key issue is high heterogeneity. No clear factor explaining variation. So the insight is exercise remains the most reliable intervention. Implementation challenges. First is identifying high risk individual, often based on fall history. The limitation is cannot prevent first fall. Intervention delivery, exercise, group programs, physical therapy, both are effective. Adherence issue, multifactorial intervention, multiple referrals, complex pathway, require case management, follow-up system. Type of exercise program, common evidence-based programs, Otago exercise program, Tai Chi, standing tall, weight-bearing balance training. So the main point is multi-component exercise is most effective. Limitation of evidence. So the key limitation was focus only on fall related outcomes, excluded functional outcomes, cardiovascular benefit, limited applicability to severe neurological conditions, lack of consistent harm of reporting. Future research needs required better primary care, feasible intervention, improved adherence strategies, inclusion of diverse population, more trials needed in mild cognitive impairment, osteoporosis, intervention. So final conclusion is exercise should be the first line of strategy and multifactorial intervention should be a supportive approach. Exercise evidence support fall prevention strategies, implementation remains the